Hello, 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 and welcome back to episode 5 of Rad Talk, where sports and medicine collide. I'm Dennis, that's Gage, and we're going to be talking about a whole bunch of stuff. I'm just going to do a quick recap for you guys. We touched on some of the travel stuff last time. Gage touched on some of the undergrad, beginning of medical school stuff, which he's going to elaborate on. I'm going to jump into some more of the travel stuff. So last time we ended with okay, the travel pay, you're going through the interview. We're going to start with, okay, now you got the offer, you've accepted. Where do you go from here? And now you're going to start getting a bunch of emails to go and get your vaccines if you need to get your flu shot, or if you need to get your tuberculosis check. So you're going to go do that. You're going to have to go get a physical. You get drug tested every new job you get. You also, yeah. So if you take a new job every 3 months, you get drug tested every 3 months. Okay. And so you're also probably going to get sent a message from the manager about whether that's orientation, or different. Also, you have to do different modules for the company that you are working for, as well as probably modules for the hospital, whether that's going through, how to lift people properly, whatever modules that particular hospital mandates for their employees. And so in the sonography world, you have to also take a sonography test. It's a competency test for the company that you're working for. And usually you have to do that once a year, unless you're switching companies, then you need to take that particular competency for that company. And so these are all the things that you got to get done before your start date, which can vary. I mean, if they needed you in, usually they give it about 2 weeks or so, because you need to be able to get the drug test, do those things, and it needs to get back to the hospital as successful and that you passed, and before they can allow you to start. A little tidbit, I'm going to give you a little nugget here. The hospital sometimes will say, we need you to get this particular pair of scrubs. We all wear gray, and we want you to wear gray. And I used to do that. I used to find those scrubs, and sometimes it was a pain in the neck, depending on where I was living, and you got to get it, mailed to you in a time frame, and it's kind of crunch time. And so my
Can't you
nugget,
use the hospital ones?
My nugget is, if you have other scrubs, typically, if you wear that to the hospital and you say, hey, like, my scrubs haven't came in yet, are you okay with this? They usually don't care. It's usually per policy that they have to forward you that wear these particular scrubs. And I used to do that. And then once I just was just like, oh, okay, I have this pair of scrubs. They don't care. I've been to a lot of hospitals and they don't care usually. I've never actually been to a hospital that really cared. I think, and I think Gage is probably another thing. I think you could probably get away with wearing the scrubs from the hospital, whether that's from the OR scrubs or whatever. That's something that I haven't done, just because I like my scrubs with my nice pockets. And also another nugget. Typically, the company that you're working for factors in the price of scrubs. And so if you need to buy scrubs, that's reimbursable, because that's something that you need for the job. Also, another little thing is reimbursable is your license for that particular state. Now, in ultrasound, I believe there's only four states that you need a ultrasound specific license: New Mexico, North Dakota, Oregon, and New Hampshire. I think that's 4. And so they'll reimburse you for that as well. Also, parking. Like, I've worked in Los Angeles before. I know I'm like going inside. Worked in Los Angeles, and I worked with people there who parking, it was $15 a day just to park at the hospital, which adds up. Oh my gosh, $15 a day. That's, work 5 days a week. That's a lot of money. And so that's also reimbursable through the company. And so these are questions that I highly recommend before you take the job. Find these things out, and make sure that the company factors that into reimbursing you for these expenses. Okay, so you've got the job. You're going in day one. You get to meet all of the the rads, everybody in radiology, the sonographers, whatever, the nurses. And so I think the most important thing I can say going into it is like, and I know this is try to fit in
Yeah.
to the best you can, because they do things a certain way, and you don't want to be the one who says, well, at this place we did it this way, and
Yeah.
at place we did it this way, because people are going to they're going to be like, well, you're not in Kansas anymore.
Hmm.
um,
Yeah.
like we do our protocols this way, we have this set up, and you need to follow along with what they say. That's been a hard time with for me, just for various things. Sometimes just an example, I do a right upper quadrant in some places, and we can just look at the gallbladder, and where I do a
Hmm.
right upper quadrant at this place, and I look at the liver and right kidney, gallbladder, and I do a right upper quadrant here, and it's everything minus the pancreas, or add the pancreas. And so
Yeah.
these little short little things that you just have to kind of remember. Um, the weirdest thing, not the weirdest, but the most unique, I can say weird, most unique
Yeah.
thing that I think I've ever seen was these rads were familiar with the old B scanners, which I've never worked on before, because it's very archaic, I think.
Yeah.
But all of their ultrasounds were done from right to left, and you did no labeling of any organs ever.
Oh God.
So you just wrote like sagittal right, transverse right, sagittal mid, and it was from thyroids to the abdomens to
Yeah.
everything was done just right to left. You didn't label anything, which was very difficult to get used to. But again, you do it the way they want you to do it. Now, if something is, you know, in a like completely wrong or like scary or something, obviously bring that to somebody's attention.
Yeah.
But the radiologists make these protocols, and they typically go along with like ACR guidelines or other
Hmm.
guidelines that are recommended. And so do it that way. Um, Another like little bit is some hospitals have you clocking in and out, and some don't. And so uh, my thing is, and when I first started, I would ask a lot of questions, like where do I clock in and out at? Where do I um, do this at or that at? And then I think I've learned that I don't ask as many questions because I just want them to tell me how they do it.
Hmm.
Because I feel like the more questions I ask, the more doors, the more Pandora's boxes I can open. And
Yeah.
so if you ask me, if you tell me I need to clock out here, then I'll clock out here. If you don't tell me I need to clock out here, then I won't clock out here. Um, 'Cause usually the clocking in and out doesn't make a difference on our end, because a lot of times what we're doing is we're sending our time cards to the company, to the travel company,
Yeah.
and then we're getting it. You have to have a manager sign that, and then the travel company is sending it a copy to the hospital or to the HR, and so they have records of it. The travel company has records of it, and then you get paid appropriately. You have a manager or supervisor or lead or whomever they designate for you to sign that piece of paper for you. Um, and I also wanted to kind of go into a a brief overview of sometimes like a travel assignment might not work out. Um, I've
Hmm.
worked, and this is kind of like taboo. I don't hear a lot about this, but this is just a little tidbit. I've worked with different folks that literally I'm working side by side with, and they were let go. I worked with somebody that I'd worked with for a week, and I was doing training, and I can tell you that this individual was let go because he was a jerk.
Yeah.
He literally he was
Yeah.
and he'd started, and the sonographer started to complain about him, how he was talking to them. He was taking exams that he wanted to do as opposed
Cherry
to like,
picking. Yeah.
yep, he was cherry picking
Yeah.
the exams that he thought would fit, be easiest or was whatever for him.
Yep.
People start recognizing that, and sometimes you can get away with that, but don't be a jerk. um, and,
Yeah.
and 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 next thing you know, by the end of the week, people were asking me, and I was like, well, that's just how he is, how his personality is.
Yeah.
And by the end of the week, he was gone. They got him out. I also have worked with other folks that um, maybe weren't as competent, And so they noticed a huge drop off from their full-time sonographers to this traveler who's come in. And so a lot of places I worked, I don't know everything. And so I've learned a ton of stuff everywhere I go, whether it's from the doctors or the sonographers, or, sometimes you do, an ABI or something, you haven't done that in a year, or hips or something, you haven't done it in a long time. And you go in, you're like, hey, I think if you're honest and you're forthright with that, with the managers or, the company and things, and you come in there, you say, I haven't done this in a while. People, I don't know if I've been extremely lucky, but people were more than willing to teach me or to walk me through the process again. Understand that, like, I'm being honest, like, I don't necessarily remember how to do this particular thing. Like, show me how to do it. Give me a couple times. And I've never had any pushback. I don't know if that's just unique in the sonography world, that we're always trying to, like, learn new things or remember how to do other things. It's like riding. I know it's like riding a bike. Sometimes if you haven't done it in a while, sometimes you need a little bit of a refresher, and that's okay. I don't want anybody to be discouraged on, like,
it's just too much to know for us to remember how to do everything all the time.
Right.
So.
And especially if you're working at, different facilities. I mean, some departments in sonography world, they don't do vascular at all. Or some departments don't do second and third trimester OBs at all.
That's how it is here. Yeah.
And so you're like, if I'm working in a place there for extended period of time, and I'm not doing second or third trimesters, and then I go to a hospital and they're like, well, we're going to do a lot of second and thirds, we're going to do anatomy scans, we're going to do full fetals, we're looking at the heart, LVOT, RVOT, and you're like, well, I have not done that because I've been working in this particular place for 6 or 7 months. And so I think there's that understanding that we're willing to show you, we're willing to teach you. We'll take time with you. I've even had places that exams I've never done before, whether that was some MSK stuff or some TCDs that is, I think, a lot of times done by echo or vascular departments that they did there, and they were willing to show me. And I was just like blown away that not only have I never done this before, but you're willing to take the time and make sure that I become competent at it, knowing that I'm going to leave. And I think that goes back to being open and honest, trying to fit in, trying to be nice. Is Sam making a presence there?
Yeah, she's trying. Yeah.
If you're listening, Gage's cat Sam makes a presence from here and there. So, but yeah, and so I think those are all important things. Just be like a respectful, open, honest person. And I think that's going to go a long way, because as a traveler, people are looking, you're filling a need, and you're there to help the department. And some departments are going to bring you in and they're going to abuse you sometimes because they feel like you're getting paid a lot more than them, and so they feel like you should do double the amount of work. And if something like that happens, I think it's important to have a conversation with the recruiter, have a conversation with the manager. Know that you're only there for a short period of time. And so if you feel like it's not worth those conversations, you can just push through, make a mental note of how that is. Hopefully they acknowledge that you're a person, and that, this is a field that, has a lot of injuries, and that they don't want you to get any more hurt than you want them to get hurt. And so we all kind of carry that burden. And I think, and I understand, because before working with a traveler, or before being a traveler, I've worked with travelers before. And I've felt that way. You're making so much more money, but that was before I took into account the expenses that we had talked about on prior episodes of housing and yada, yada, yada. And so, I just wanted to touch on.
I was always interested in the dynamic, because it's the same with residents and attendings, right? They're paid exponentially more than we are, especially as a fellow. They do a little bit more work than I do, but they don't do much. So I understand the being angry about the pay discrepancy.
It's tough. And I think if you want to, especially now, or especially anytime, I guess, I feel like I've become more aware that I'm excited for any individual that is able to go out and get what they feel they're worth. If you can get what you feel, financially that you're worth, like, kudos to you. I would rather be mad at the hospital.
Yeah.
It's the entity, the big entity that's not paying other people appropriately, or isn't taking care of their employees appropriately, that's maybe causing some of these turnovers or causing these traveler issues. I mean, sometimes traveler issues are just caused because a couple people went on maternity leave at the same time, and you're just kind of in a rut.
Yeah.
And then other times it's being mismanaged. One of the top reasons people leave their job is management, supervisor. They don't get along, or they don't see, they're being overworked, various reasons. And so you see those, I see a lot of those kind of things too. And so I think I would be more hard pressed to be upset with the hospital and not the individual. Take care of your people will take care of you.
Mm-hmm.
And so, yeah, those are just kind of some of the brief things I was going to talk about getting into. I know the next thing we're going to be jumping into is Gage is going to continue telling us about medical school and the wonders of that. And that's why we named this episode Medical School. When does it all end? So,
so last time we talked up to medical school, right? Like I talked about the MCAT and all that kind of stuff.
Right.
So now we have to assume that you've taken the MCAT, you've done well, grades, you got it, all that stuff is taken care of, and you've applied. I think I talked about the application process for medical school last time, so we'll just assume you've been accepted. You've been accepted into medical school at this point.
You said you applied to 30 or 40.
Yeah.
Different
with
schools.
The expectation that you won't get invited or interviews at all of them. But the more you apply to, the more interviews you're going to get, with the downside of it's going to cost you more money.
Right.
So we'll assume you've been accepted into medical school. And I can talk about, my experience where I went to medical school and all that kind of stuff. But as a general overview, there are two different types of, I don't know how to describe medical doctors, I guess, two different types of doctors. Most people are familiar with the MD, the medical doctor. I'm actually DO, which is the other version. For all intents and purposes, there's no difference. We all do the same thing. The training is roughly the same. So once you pick one,
and now MD medical doctor, DO, it's doctor of osteopathic. Is that right?
Yeah. So MDs are allopathic doctors. We're osteopathic doctors. It's supposed to be more like holistic, I guess, a whole body approach. I don't know that that's actually true, but
still Western. It's still Western medicine.
Yeah, still. Oh yeah, very much so. Right. So you can pick either one, but once you do, the application process is the same. So once you get to I can only speak to my experience at an osteopathic school, but the MD school is going to be roughly the same. So it's 4 years, right? So it's the same amount of time as undergrad. The split is 2 and 2. So your first 2 years is all classroom work, well, mostly classroom work, where you take you do biochemistry, anatomy, physiology, all the general stuff you would do, pharmacy, all that kind of stuff that you need to learn basic knowledge. Some of it's basic first year, and then you build on it your second year, so you're ready to go into the hospital. But the first couple years are pretty eye-opening for a lot of people. I think I don't remember, maybe a couple weeks into my first year, we took a quiz. It was worth like 6 points or something, but I studied for like 3 hours.
Oh my God.
And I was like, oh my God, this is not, this is what I have to do for the next, for the rest of my life, but at least 2 years. So I knew then that it was not going to be, because for a lot, like I talked last episode, a lot of people can coast. A lot of doctors are smart enough they can coast through college. Some of them are smart enough to coast through med school, but those are like the elite, very few. But most of us, when you get there, you're like, oh my God, you're not ready for this. It's a lot more hours than medical or than college. So you're taking more classes, you're doing more stuff. The content is not necessarily harder. It's more the volume. It's just a whole bunch of volume at the same time, because you're taking all these classes that was on biochem, anatomy, phys, anatomy lab, all this stuff you're taking at the same time. It's not broken down. So for me, the volume was very tough to adapt to. But essentially what happens is you do the first it's broken down into semesters like college is, but you do 4 semesters, so 2 years, um, where you learn the basics, uh, basic medicine, all that kind of stuff. And then once you finish the 2 years, you go in the second 2 years, depending on who you are, might be better. I'm not a huge, we can get into it at some point, but I'm not a huge clinician, which is one of the reasons I chose radiology. But the last 2 years are the clinical years of your medical school. So the first year and a half ish is kind of what's the word? Like
Like
laid
that.
out for you. Yeah.
Okay.
So it's they're set. So you have to do internal medicine, you have to do peds, you have to do OB, you have to do family medicine. Like you don't get the pick. You have to do those
Mm,
core rotations. And
yeah.
then there's some electives built in. So once you get into like the end of your third year, you're like, okay, I'm starting to think I want to do radiology. I want to do one that's not, if you want to do something that's not one of the core, radiology is not a core rotation. So I had to do an elective. If
Mm,
you want to do most surgery rotations are just general surgery. So if you want to do plastics or orthopedics or neurosurgery, you have to take an elective. So the first part of your third year
does that
is
add
laid
on to your
out.
now? Does that add on to your time gauge? Like if you're going to take
No.
elective?
So it's all built in.
Okay.
So the core rotations you do first, and then
Mhm.
they give you time at the end to pick your electives to do whatever you want to
Okay.
do. And you can also take your electives in things that you've already done. So if you know you want to do internal medicine, then you take an elective in maybe either internal medicine or one of its subspecialties like cardiology or GI or whatever.
So
Um,
if you're family medicine, if you know, okay, I want to go family medicine, you could take,
yeah,
you already took your regular class in family medicine or whatever that is, and now
yeah,
you're taking an elective more
hmm
into family medicine doctor or
yep.
whatever. Okay. Okay, I
So you
got
either
you.
get more exposure into family medicine or you get exposure into other things to make sure you don't want to do it. Like family medicine is what you want to do.
Gotcha.
Um, I knew I knew about 5 minutes into I think I started with internal medicine and
Okay.
I started outpatient. So we started in a clinic
Hmm.
and it was 5 minutes into my first um, like history and physical, and I was like, I cannot do this. So I
It's
knew
not.
immediately I didn't want to do any kind of clinical medicine,
Yeah.
which
Yeah.
eliminates everything for the most part except what I chose and
Yep.
pathology. Pathologists they don't do clinical medicine either.
Right.
Um, so once I figured that out, it's getting down the road, but radiology was an easy choice once I figured that out.
Yeah. Yeah. Yeah.
Um, so like I said, the first 2 years clinical or preclinical and then clinical. There's also some exams along the way. Doctors get tested a lot. So not exams like the quiz I was telling you about. Everybody has those
Hmm.
as well. But there's three what they call step exams. The first one is called step one. They're all just numbered. But step one, which you take after I think it's after your second year.
Hmm.
So you've learned all of your preclinical stuff, and now you have to go take an exam. So when I went through that exam, in large part dictated what specialty you could go into. So if you didn't score very well, you weren't going to go into a competitive subspecialty, which is usually like your surgical subspecialties are very competitive.
Hmm.
When I went through, radiology was competitive, anesthesiology, stuff like that is more competitive, whereas stuff like family medicine, peds is not as competitive.
Hmm.
Um, so most people study 6-ish months, like dedicated studying for 6 months.
Hmm.
And then you take that in the summer before you start the clinical years. So assuming you do well on step one, that opens a lot of doors that wouldn't otherwise be open if you don't score, and it can make up for a lot. So if you have poor, because you get graded on everything. So if you have poor like clinical scores, but you have a good step one, that can help.
Hmm.
It can cover some red flags, but it can't cover all of them.
Right. Right. And so you do your first 2 years, and then you take this test, and then that just
Hmm.
helps you decide for your first didactic years, basically, and
Yep.
then to the clinical side for the following 2 years. Take a test, and
Hmm.
that can help decide if you're going to specialize into something that maybe is a little bit more competitive than other things.
So yeah, step one determine the first after the first 2 years. It's kind of ironic, but that first test will tell you a lot. Even if you think you want to do orthopedics and you score poorly on that test, you're not going to do likely not going to do orthopedics.
Yeah, yeah, yeah.
So you take the test after the clinical years. So then you do a year of your third year, which is the clinical year. You do that, and you take another exam after that third. Usually, most people after the third clinical year, and that focuses more on clinical medicine. So the
Mm-hmm.
stuff you've been learning in clinic, you'll get tested on. It has some, physiology and all that kind of stuff, but less than step one.
Mm-hmm.
Um, so that is, there's been a shift. They're all graded. When I went through, they were all graded on a 3 point scale. Since I've graduated and moved on and into residency and fellowship, they have now made step one pass fail.
Oh,
So
wow.
you don't get a score anymore. So the programs can't use it as like a barometer. They just know that you passed or you failed. If you failed, obviously that's a barometer. They don't likely you're not going to get accepted. But if you passed, they don't know where on that spectrum you have fallen. You could have been in the 95th percentile or just above failing. They have no clue. As far as I understand, I don't know if maybe the candidates get like a score themselves, but the program
Yeah,
doesn't
yeah.
see it.
So if you fail, what do you like? What happens? I don't know if you know the answer to that.
So I mean, nothing happens. You can retake it,
Okay.
but it looks very bad if it takes you multiple attempts to pass the exam.
Uh,
Programs won't look. Your options will be very limited. If you get
gotcha.
in my experience, if you get in, it's going to be at a program that's less than ideal. So it's going to have a whole bunch of red flags, but you really don't have a choice because
Right.
of your resume.
Right. Right.
Um,
And I'm sure you can make the best of that. It doesn't
yeah, most
necessarily,
people usually do. Yeah,
because it's all about what you're going to put into it. Maybe you don't
yeah,
pass, and you put more into it. I don't know.
yeah.
If you're a bad test taker or something, they exist. So
They do. Yeah, a lot of people have. And you're not. You've never taken. I mean, the MCAT, I guess, but the
mhm.
MCAT doesn't compare to the step
Yeah,
exams. So you've never taken an exam, one like this, two that has this much importance on your future.
real life. Yeah.
So there's a lot of people that find out their scores, and you can tell they either did better than they thought, or the opposite, where they're like you can tell they didn't do as well as they wanted to.
Mm,
Um,
it's tough.
yeah. So then when you take step one, do the clinical, then you take step two. But what I was saying is when I went through step two it's not that important as long as you don't go in the wrong direction, meaning you don't score significantly lower on step two than you did step one.
Mm,
Um, Now, with step one being pass fail, the importance has been shifted to step two. So
mm,
programs will now, some programs I think I've heard from the medical students that come through that I've
mhm.
talked to that you have to take step two before you can even apply.
Wow.
So they've already shifted the focus onto step two.
Hmm.
Um, so then you take that, assuming you do well, whatever.
Hmm.
And then the last one, there's another one, step three, but you don't take that until you get into residency. So there's
Oh,
two board exams in medical school
man.
on top of all the other countless quizzes and tests you had to take along the way.
Yeah.
Um,
They're
so
just
that's
trying to
why,
weed you out. They're just trying to.
yeah, that's why doctors get angry when people come in and they're like, "Oh, I looked at Google, for
Hmm.
like no disrespect, but you like looked at Google for 30 minutes and like
Hmm.
we've been tested a million times on this stuff.
Right.
As long as it's within our field, if you're asking us something that's not in our field, then there's likely you do know more.
Yeah,
But if you're coming to me about a radiology question, you're not going to know as much as I know,
for sure.
having done, what, I'm 6 years now. So,
Yeah. Yeah. And and now even and so all these testings, I think I've talked to you before, and you said medical school did not get you ready for to
mm,
be a radiologist. You're like,
yeah.
medical
So,
school, nothing to do with me
yeah,
becoming complete.
radiology is unique at a lot of schools. A lot of schools don't prepare you to do radiology,
Hmm.
um, just because a lot of people don't know how to do radiology outside of radiology. So, if you don't get a radiologist to teach your medical school, then good luck.
Hmm.
Um, And it's also not important because I don't know how many kids I graduated with, but only six of us went in to radiology
Oh,
out
wow.
of maybe a couple hundred. Like it's not very common. So
Yeah.
you can't really uh, cater to the few. You have to cater to the many.
Hmm.
Um,
Makes sense.
so medical school is largely designed for people that will end up in general practice, so like family medicine or internal medicine, peds, OB. It's largely geared towards them. It's less geared towards people that want to do what I did, anesthesia, any kind of surgical subspecialty is not really taught about in medical school. So it's largely, at least American medical school is catered to people that want to end up in general practice, which is for a reason, right? They're more important than we are. Like, frankly, there's a huge shortage. Yeah. There's a huge shortage of them. So there's a shortage of doctors in general, but
for sure. Yeah. And I mean,
so,
and I even, I mean, I know I'm bouncing around even a little more, but I've worked with radiology assistants before that I think I've only worked with one radiology assistant before, but that was the person that was kind of similar to a PA that was doing radiology procedures. And so I never.
Yeah, they're radiology specific, whereas a PA is not radiology specific.
Right.
PAs are actually, PAs do the same, similar training to what we do. They do the first 2 years for PAs is the same as it is for us. Where they differ is the second 2 years. They don't do as much clinical as we do. And then they don't have to do residency or fellowship. So I think they can, but they don't have to.
Right. And so you guys are very, and then I mean, and even from that, you guys from radiology, and then you specialize even more. And I mean, I guess we'll get into that probably in another episode after we get through. We still got to get through your residency and then your fellowship, and then how do you specialize while you're in. I don't know if you choose. I don't know if you choose to specialize in residency. I don't know if we won't tell too much about that. I guess stuff I'm also kind of learning along the way. I don't know a lot of these things that Gage has been through, so it's kind of interesting for us all to learn.
Yeah, I mean, medical school is a unique. I did not enjoy medical school in terms of the school itself. It's also very. I mean, you've been around enough doctors, you know how they are. So it can be very. What's the word? I guess competitive is the word you would use, but these people are built different, a lot of them. And they don't really care. So it gets very hyper aggressive, hyper competitive when it comes to these taking these quizzes and all this kind of stuff.
I think you compared it best when you said sports. I mean, you get into this thing and I'm trying to force my will onto everybody, and you're looking at these people as they're going through the same thing, but you're competing against each other. I'm trying to get a better score than you to get where I want to go, and you're trying to do the same thing for me. And so they're trying to get some sort of a competitive edge, or I'm sure and then you have all these type A personalities. And there's this, I think, old adage of how different nurses are compared to doctors. And I know nurses are competing as well through what they're doing, and everybody has their own competition, especially in healthcare. Everybody has to compete for their jobs, or schooling wise. But doctors, they're super focused and they're constantly learning, and they're constantly being tested, and they're probably constantly stressed out, and you're lacking sleep. And
you do get tested a lot. Yeah, there were nights. If you're a good studier, you'll break it up, over time. No, most people were. I vividly remember staying up all night, just countless times, studying because we had block exams, so we were tested on every subject at once. Some schools that you'll get tested on anatomy, then physiology, but we had all ours at one time. So you're trying to cram all this information, and it was the first time I was ever trying to learn information long term. Because this wasn't like in college. I knew I could just forget this because I wasn't going to specialize in biology. I just had to remember it for the exam. Boom, it's gone. But in medical school, you can't do that. You're trying to remember this stuff for the long term. And it was the first time I'd ever had to do that.
Which I'm sure is incredibly difficult for a lot of. I mean, you guys are being a doctor. You're very smart, obviously. You're usually some of the top performers of schools that you're coming from. And so to then having to be able to have to retain information, you don't have to just memorize it for the test. And you're like, okay, I don't need to retain this. Now you're like, okay, I need to remember this for forever if I can. I mean, this is all beneficial, working towards what you want. And so I'm sure that's unique.
And that's the first time you get exposed to patients, right? Because most of us Like you have standardized patients, but sometimes you had to go out and see like real patients during even the preclinical or the clinical preclinical years. You had to go see standardized patients. Sometimes you had to go see real patients. Then you get the third and fourth year, and you have at least a baseline knowledge academically, but you have no clue what you're doing clinically. You know, you can practice a physical exam and all this other stuff that you want to in medical school in the preclinical years, but it's a different story when you're actually like it's a live person and you have to listen to your first heartbeat, and then you
Right.
know you have to get the history, do the exam, and then you have to go tell someone, the resident or the attending that's above you,
Right.
and knowing they're going to repeat the exact same thing and they're probably going to find stuff that you didn't find. So you have to get
That's
used to being wrong
mhm.
and kind of embarrassed
Yeah,
very
yeah,
quickly.
right. And I think this is something you're going to even touch on more in residency. I can remember certain doctors really
Yeah.
pushing you and making you feel like, you don't know what you're talking
Yeah.
about, or
Yeah.
you're inferior, or you're,
Yeah.
and everybody reacts to those situations differently. And
Yeah.
some people fold, and then some people it pushes them to be better. And,
Yeah.
and so I'm sure that's a whole host of other
I mean,
things
it's
that,
just something you have because even now, as a fellow, I'm
mhm,
a pseudo attending, right? I'm
yeah,
6 weeks away from being the only name at the bottom of the report, and I'm still like, you
hmm,
still make mistakes. I watch people that have been doing this for 30, 35 years still make mistakes. They miss things.
hmm,
Um, so that was something that I had to get used to more so in residency than medical school, but it's
right,
something that doctors have to get used to, and it's something that's hard to explain to a patient, a
right,
non-medical patient, that like we're going to make mistakes,
right,
and
yeah,
unfortunately sometimes it's going to cost lives and it's going to harm people,
right,
which hopefully it wasn't done on purpose or whatever, you know,
yeah,
that
yeah,
kind of stuff, but it's going to happen.
right,
But I feel like I was just talking with my attending this morning about, I think I'm going to sound like a typical doctor here, but some patients have kind of the expectations are unrealistic when it comes to doctors.
mm-hmm,
Like no one expects you as a tech to be perfect,
right,
right? You're going to make mistakes, but when it comes to the doctors specifically, they think, "Oh man, you guys should never make mistakes. You should be perfect." Yada yada yada.
yeah,
That's not how it works.
it's tough. And I think, yeah, I think, and not working in the healthcare profession is like not in that industry. I think as a person, other
Hmm.
people that I talk to, you say, they trust their doctor.
Yeah,
You forget sometimes that, like, doctors have hard days, doctors have
yeah,
families, doctors
yeah,
go through life things, and
hmm,
or they're tired, or kids are stay up too late, or
yeah,
things like that, and you make a little mistake, or you do something here.
yeah,
No one's perfect, and like you said,
yeah,
we're trying to, or you guys are trying to not make those mistakes. Like, we're all trying to not
yeah,
make mistakes,
hmm,
but things happen, and
yeah,
you hope that it's a little mistake and it's caught somewhere, or
yeah,
whatever that is, because you guys, everybody takes that oath, do no harm.
hmm,
And so I
yeah.
think, uh,
And radiology is kind of, well, again, we're getting kind of ahead of ourselves, but radiology is unique in that most people don't know we exist, right? So if you get a X, maybe ultrasound because they see you and you're like, oh, I'm going to go talk to the radiologist about this, whatever. But
yeah,
especially if you get like an X-ray or an MRI, they never see us.
mhm,
So I assume that a lot of people assume the person that tells them the results is the one that the patient thinks read the scan,
mm,
right? So
right,
if a surgeon tells the patient the results, he may have read the scan, but
mm,
my name is on the report.
right,
If family medicine, like they may tell you, hey, your DEXA shows that you have osteoporosis, but I was
mhm,
the one
yeah,
that said, hey, you have osteoporosis.
right,
Or if you have stage 4 cancer, likely I was the one that said, hey, you have Mets here, 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 and here.
right,
Um,
right,
so we exist in the dark, and I think most of us are okay with that. But
yeah,
it's hard to explain what radiology does because most people don't know we
right.
exist.
And I think even sometimes that I feel like some doctors that order the exams, or nurse practitioners, PAs,
Hmm.
um, I feel like sometimes they leave certain portions out of not, I don't know,
Hmm.
not telling the patient,
Yeah.
um, whatever it is, they have gallstones. And so they say, yes, you have gallstones, or yes, you have this, but we didn't tell you had a kidney cyst. It wasn't really relevant for me to tell you, not a big deal, but
Yeah.
I feel like a lot of times I'll be like, oh, okay, I looked at your last study and we're just kind of following up a kidney cyst. And they're like, I didn't know I had cysts, or I didn't know. It's not a big deal. But I feel like the doctors or nurses or whomever orders these exams, sometimes they leave little bits and pieces out that's in the radiologist's report. So I think if anybody's listening to this, I think it's beneficial and I think I try to tell all my patients that I get to see, request your reports. Look over the reports yourself. That's your medical record. This is your history. This is your life. It's great to always, trust your doctor if you believe in your doctor. But I think looking at your own reports and having those on file, even if you move somewhere else, if you go from state to state, I think and you want to say, okay, here's my documentation from wherever I was at prior. I think having those things are super important.
Yeah.
And just in my opinion. So should we, is there anything else you want to go over medical school wise, Gage?
I don't think so. I think covers it. That's right up to, we can talk about applying for residency next time, because you do that obviously in medical school, but I feel like that's more of a residency thing than, so we'll lump that in next time.
Did you want to hit a couple of the questions?
Yeah, I know we have some left from last time. Let's go ahead and, how many do we have?
We have 4, and we briefly,
I think we can do them all.
Yeah, I think so too. And these are, I'm just going to shoot them to you. It says, why, and tell me the best you can. Why isn't it standard practice to test a D dimer before doing a PE study? Now, before you tell me, these are questions that we've got via social media or via people who have asked us. And so we're just kind of trying to answer your guys' questions.
This is actually kind of fun. I like answering as long as they're radiology specific. Don't ask me, fair warning, don't ask me any medicine questions, OB, peds, don't ask me any of that unless it's related to radiology.
MSK,
this question you just asked me is more of a medicine question than radiology, but the simplified answer is that it's just the D dimer is not very specific. I think it just tests for like a breakdown of a clot, like a product of a clot that breaks down. So it's very sensitive. So if it's negative, you don't, like, a high likelihood you don't have a clot. But if it's positive, that doesn't mean you have a clot. So it's sensitive, but it's not specific. A lot of things can do it. Clots can do it. Sepsis can do it. So there's a whole bunch of things that can cause that D dimer to go up.
Injuries, iatrogenic.
Our D dimer could be positive right now, yours and ours, and we don't have clots. I'm overweight, but we're healthy 32, 33-year-olds. Like, our D dimer still could be, it's like, what's the test? The ESR, like a SED rate or a CRP. We could test it right now, just inflammatory markers. They're likely going to be elevated. It doesn't mean anything. So I think that's why they don't routinely use the D dimer for a PE. And I think there's some nuances to it, but that's the simplified answer.
Yeah, very generalized. It's good.
Yeah.
Okay. This is why. Let's see. What do you use for pediatric dosing for CT contrast?
So I don't like reading kid images or anything like that. But this is an easy answer. Almost everything in kids dosing wise is related to their weight. So there's a good website. Let me think. ctisus.com. It's run by his I think his name's Elliot Fishman. He's a radiologist, body radiologist in Hopkins. Oh, wow. And he has an education. He has a YouTube. He has all this stuff. He puts out cases and yada, yada, yada. But he has a page dedicated for like frequently asked questions, and this is one of them. Oh, wow. So they use 2 cc's per kilogram. So, or 2 mLs, whatever you want to use, same thing, 2 mLs per kilogram. So if the kid weighs 35 kilograms, they use 70 mLs. But it's all based on weight. Yeah. Up until a certain point, once they reach like 14, 15, 16, and then they're like a normal weight, then you just use a standard adult dose. Yeah.
Gotcha. But okay, cool. Mostly based on weight. Very good.
Yeah.
Is it common for radiologists to ignore GFRs under 30 who aren't on dialysis to give contrast for non-life-saving procedures?
So this is another thing that Fishman talks about. He links a whole bunch of articles. So contrast alone is not a risk for contrast-induced nephropathy, which is what these people are referring to when they say the GFR is low. So for non-medical listeners, contrast-induced nephropathy just means you give contrast and your kidneys fail, right? Everyone's heard about it. But contrast alone is not enough to do that, according to several studies. So the GFR is just like overall is like a function of your kidneys. And I don't remember the numbers, but I think it's divided by 30s. So less than 30, they mentioned less than 30 because that's the cutoff we use. If they're above 90, I think it's whatever. You give them the full dose. Between 60 and 90, I think it's kind of up to you. Once you get below 60, that's when you start looking to reduce the dose, but you can still give it. So this is the one I told you about off camera where it's kind of preference. They're saying non-life threatening. So I think most of us as radiologists do the risks or the benefits of the procedure outweigh the risks, or the scan outweigh the risks. So is the patient going to live? They say non-emergent in this question. So I would say most of us probably wouldn't do it. But I think that's what most of us look at is, will the benefits of doing the scan outweigh the risks of not doing the scan? Then we don't care about GFR. You're gonna have to accept the consequences of your kidneys failing, or the patient's gonna die. So,
and I think you guys, this is something that you would probably go over with the referring physician or PA and say, hey, like you guys, and these are the important conversations that you guys say, hey, this could happen, this could happen. Are you willing? Make sure we go over all these things with the patient. You go over everything with the patient's doctor, and then you guys come to consensus together and make this decision of doing what's best for the patient. And like you said, the numbers might, off the top of your head, might not necessarily be exact, but that's the generalized way of going about it.
It's a very hot topic. Nephrologists are big on it. Obviously, right? They take care of the kidney.
For sure.
So if they're seeing a nephrologist, you could talk to them to do the benefits. Are they okay with us giving contrast or But if it's like a routine thing and the kidneys are trashed, I don't think most scans you can get away with not using contrast. Contrast just helps quite a bit. IV contrast, oral contrast, it doesn't matter. But I think most scans you can get away, or can you use a different modality, right? Could we do ultrasound instead of CT? Could we do MR without contrast instead of CT? So if you can find a different modality, that's another. So I think the thought process is, 1, risk versus benefit. 2, can we find a different modality? 3, if we can't, can we see what we need to see without contrast?
Gotcha. Okay, and our last question here, and I think we talked a little bit about this. Do you think diagnostic imaging is taken away from hands-on patient care?
if any clinician listens to this, they're going to get angry, but the overwhelming answer is yes. I don't know how much of it comes from doctors versus like advanced practitioners, NPs, PAs, but my experience would be the ER specifically. A lot of times we become the physical exam, right? So they just get a lot of where I came from for residency, and I think maybe here, don't quote me on that. They have like a person, usually like advanced practitioner that sits and triages, right? So if you come in with belly pain, they triage it, and they are the ones that order imaging. So a lot of times we read the imaging before the physician has even seen the patient. So I think the answer is yes. But
I think, and I think with this, I think even some places have not even advanced practitioners. They have, nurses that are triaging patients. And so you don't have, NPs, PAs, physicians. You have nurses that are order, the patient has this particular thing. And so the nurse is saying, well, I'm going down the list and if they come in with this is what we order. And we put this in. And then the practitioners or the doctors go along with what the guidelines they've set up. And so, like you said, before anybody lays hands or sees the patient as an advanced practitioner or doctor, they're just ordering these exams. And sometimes, sometimes I've questioned or called the practitioner, the doctor and they're like, no, that you're right. That doesn't make sense. Like, let's not do that. Let's hold off on that. And sometimes we end up doing it down the line. And then sometimes, it's not something that's necessary. And so I think that's where all scopes of medicine, we all, you don't, I don't know. I don't take anything personally in medicine. If I'm reaching out to you and I have a question, or if I have something I want to say to you and you say, no, I think we should do this, or no, I don't think we should do this. I'm just saying, I'm just bringing this to your attention if it's not already brought to your attention. And, it's kind of like an extraneous example would be like if a stewardess is on an airplane and she thinks she hears something wrong with something, and the pilot, they're all going, they don't hear the same thing. I think it's appropriate for the stewardess to say something, even if it's like, oh no, that's supposed to make that noise, or whatever it is. There's nobody that's above anybody else. And I feel like, especially as somebody if you're new in the medical field, don't feel like you're inferior to anybody because you have an opinion or a question or something that you've learned. Bring that to somebody's attention, and don't worry if they take it personally, because our job is to do what's best for the patients. And if you bring in question, upset somebody, then so be it. Let that be. But yeah, I think
I have my last blurb here. Every time a medical student comes through and they're not interested in radiology, I tell them the same thing. And this applies to this situation. So one, they made the ACR made a guideline called the appropriateness criteria. If person comes in with abdominal pain, you go to the page that says abdominal pain, and it will rank what imaging you should order if any imaging is needed. So one, people should be aware of that and use it. Two, you mentioned about having questions and calling, and I always tell people that I would assume most radiologists, myself included, would rather you call if you don't know, one, if you need an exam, two, what exam do you need? Just pick up the phone and call the reading room. We'd be much happier to answer a question to get the correct exam than be pissed when you order the wrong exam. We have to read that exam, and then we tell you which exam is the right one to read, and then we have to read that one as well.
Right.
So always pick up the phone. And then lastly, when it comes to imaging, the question everyone should be asking, in my opinion, is, will this change management? So if you want to order imaging, how is this going to change? If we find something on here, how is it going to change your management going forward? If it's not, don't order the exam. Don't order something just because you can order something. So that's kind of the blurb I always give medical school that aren't interested in radiology, because I think it's important for them to know.
Yeah. And I think that's a great thing too, that you say that, because I think I've talked to PAs and things, and sometimes they're not sure about something, and I literally just told you this. I did an exam on a patient that had a pulmonary embolism and then had a DVT in their legs. And we were also looking for a DVT in the arms. And, sometimes things don't make sense, and we do certain things. And it's like, what, like you said, does this help the management of the patient? And is it going to change that? Yeah, that's a great way of forming the question. And so those are the 4 questions that we've gotten so far that we wanted to review. And I know this is probably
my turn.
Gage's favorite part here coming up.
I have a whole bunch of questions. I want to figure out which one I want to ask you.
Okay.
Let me pull up our little
notes
here.
Let's see here what we got.
I have a couple.
Okay.
That I could ask. I'm trying to think which one would be shorter. We're getting kind of long here.
Yeah. We've got probably a couple minutes left remaining.
Okay. I'll ask. This is kind of, it could be in depth, but you can keep it quick if you want.
Okay.
If money was not an issue, what job would you have? What would you have done with your life? Like, what career would you have picked?
Man, I think if money wasn't an issue, I would probably, if it was in terms of a job, I think I would have probably done something in sports. Whether it be, I would have tried to be in a locker room or an announcer or something sports related, which medically, I guess, I could do ultrasounds on athletes and things like that, which I've done on athletes, maybe not necessarily professional athletes, but I think anything that I would want to be a part of, I don't know, a sports team, because it's just that
Yeah.
camaraderie. I don't know. I mean, that's why half our podcast is sports and medicine.
Yeah.
It's because I
Yeah.
love the sports side so much. I just do the medical side. So, and so, yeah, I think so. I think that's what I would probably go with. I don't even know a specific like job title
Yeah.
I have, but
Just something sports in general. Yeah.
put me in anywhere there's a sports,
Yeah.
whether it's
Mine
marketing.
was,
Yeah.
yeah, I mean, yeah, marketing would be fun. I always thought announcing would be fun, but
Yeah.
mine would be related to neither of the things that we talk about on this podcast. And I
Yeah.
wish I would have known that it was going to turn into what it turned into, because
I
I
have
would
a
have done
feeling.
it.
I have a feeling I know this.
Yeah, because I don't know how old I was, 2001. I remember, I forget who was on the cover, but I was big into Madden, right? So the Xbox was the first big console. I owned the PlayStation 1, and then I went to Xbox.
Mhm.
But Madden 2001 was like the first real game I just like sunk my
Mhm.
teeth into. And I remember I created this player. I played for like 11 seasons. I just wasted so much time on it. I was just like this fat little nerd just in my room for
Yeah.
hours on hours
Right.
on
Right.
hours.
Mhm.
Had I known streaming would have turned into what it turned into, that's what I would have done.
Yeah.
Playing video games. I don't enjoy it as much now just because of life and
Right.
medicine and all that kind of stuff. But
Right.
I've lost so many, like the best memories I have in my life. You know, when I'm 11
Uh-huh.
playing Madden, I get into high school and one of my friends lived with me and we
Uh-huh.
played Guitar Hero. We just,
Oh
for
yeah.
countless hours,
Yeah.
we
Yeah.
jammed out. I lost hours playing Halo, all these different games, and then Call of Duty in college. I
Mhm.
would stay up till 3 or 4 a.m. playing that. So
Right.
easily streaming video
Yeah.
games specifically would have been what I would have done.
Yeah. In the world of Twitch, I mean, once you're done, hey man, another 6 weeks.
Yeah.
We'll get our Twitch going. We'll play some video games. Maybe we'll throw it up and do a
We do need to
podcast.
get a live portion going. See if that's
Yeah, yeah. I think I don't know. We'll put something out there for the viewers, and they can watch me kick your butt and some sort of game.
yeah. The only issue is you're into more like old school,
Yeah, yeah, yeah.
like Mario and stuff like that. Probably Super Smash, all that kind of stuff.
Mhm. I do love those stuff.
Um,
I
yeah,
can, I do a lot of. I used to. I don't really play games much anymore. But I mean, I like you. I play a lot of. I used to play NBA 2K or Madden. 2K I think
hmm
was like my life when I was like in college and I shouldn't say my
hmm
life, but man, I played a lot of. I
yeah,
wasted a lot of countless hours playing some 2K, building my team up, making trades,
yep,
uh, trying to be the GM and all that kind of stuff. And then what it's developed with Ninja, um, and
hmm
all these Twitch streamers. Like, man, it's a different world we live in. And I don't know who saw that coming, but kudos to that.
yeah.
Um, but yeah, maybe we'll get like we'll
One
have
of
a
these days.
yeah, one of these days we'll get it out. Somebody maybe like us put a comment in our one of our social medias what you guys want to see us rock out, and maybe we'll make it happen. Um, and if if we can, maybe we'll play with a viewer one day or something. Like we'll see how it goes.
Yeah,
Um, but yeah, I think that
that's
covers the
gonna do
episode
it. Yeah.
today. Yeah, yeah.
So what do we got? So next time I'll do residency,
Right, right. I'll go
and
through
then we'll
some.
figure out some travel stuff for you to talk about because there's always something we can
Yeah,
expand on.
yeah. I'll hit. I'll probably touch on maybe some things that happened during COVID,
hmm
um, with traveling and now the world we're in traveling today. We'll it gives a little bit of surprises.
Yeah.
Um, and so we'll hit on those things.
Cool.
And don't remember to
Yeah.
check
What do we
us
got?
out on our social media handles, which
Yeah.
are Gage will tell you.
So we're on TikTok. We're on Instagram. We're on YouTube at rad underscore talk underscore DG. And then you can also email Dennis. We share an email, but Dennis will answer your travel questions. If you have questions about medical school or anything like that, I'll answer them. And it's radtalkwithdg at gmail.com.
For sure. All right.
But,
Well, we look forward to hearing from you guys, and also get ready for more of our sports picks
all right. We'll see you next episode.
next time, guys.